Thank you guys. I appreciate the opportunity.
You have to dance at the
No dancing for me. I'm done. My brother, though. My brother's coming up this Saturday. As we get the slides kind of prepared and up here, I just want to take a second to thank everybody for coming out. This is, we talk about opioid abuse and treatment, the opioid epidemic in general. It is the issue for our generation, okay? You cannot open a newspaper, you can't turn on the TV, listen to the radio, get on the computer without this being mentioned in some form or fashion, okay? So I feel very fortunate to be in this position to hopefully have a positive impact on a lot of the people that suffer from this problem, okay? So that's one of the first things I want to say. As they get the slideshow up, just a couple quick things about myself. I grew up in Cleveland, Tennessee. Then I went to the University of Kentucky for pretty much most of my residency and fellowship training. A lot of people ask how I got back around here, and it's very simple. My wife drew a circle around Cleveland, Tennessee, 1 hour in each direction, and she said, figure out a way to work in those places. So that's how I did that. Is it, hold on, there we go. Oh, okay. A lot of fortunate things happened to me, though. To be at the University of Kentucky during the time period I was there kind of coincided with the explosion of the opioid epidemic, okay? And so being in that area, and specifically in some of the places I worked in Eastern Kentucky, as I mentioned there was Self-Refine, it was a huge opportunity because that was kind of the epicenter at that point in time of this opioid epidemic. All the small towns across the eastern part of the state were being completely ravaged by this problem, okay? So that, unfortunately for that area, but fortunately for me, to be in and around that, it offered a lot of very unique experiences and preparation for hopefully what's to come. That ultimately led me to start in October an outpatient opioid addiction treatment facility in Chattanooga, which is what Restoration Recovery is. We'll have a lot of information about that as the night goes on. We started in Chattanooga. There will be a clinic here in Dalton, hopefully by the end of the summer. We're working through that, probably also in Cleveland as well. Okay, so that's something that's evolving that we're very, very serious and passionate about. So 64,000, that's the number in 2017 of people who died of drug overdoses. Now this is all inclusive of all drug overdoses. I was looking at the computer earlier today. There was 108,000 people in Whitfield County. So just think about the impact if tomorrow 65% of the people were gone, okay? It would be everywhere. It would be a catastrophe like we've never seen. So this is the scope and the scale of how big of an issue this is. I can't stress enough, if I ask everybody to raise your hand, do you know anybody, have you been touched by anybody, family members, friends, that have been affected by this? Everybody's hand would go up, okay? It's that big of a deal. So kind of piggybacking on that, who is affected by this? So there's nobody, it doesn't discriminate as a disease process, okay? Everybody is potentially susceptible. There's all classes of people, it doesn't matter if you're rich, poor, black, white. Of course, there are smaller subsets of people who are maybe at higher risk, but at the same time, it really doesn't matter. It unfortunately can grab certain people, even on small exposures, like, you know, somebody breaks their ankle, they start taking pain medication, and then boom, you know, it kind of takes control of their life, okay? This is the ASAM definition of addiction, okay? Primary chronic disease of the brain. You guys can read that up there. The big shift, I think, in talking, you know, with different people from different walks of life, and specifically within medicine, the idea that we have to get behind is to put out of our mind this idea of some sort of moral failing or bad choices. Not that bad choices can't lead you into certain situations, but this is a real disease process, okay? It absolutely is. And the quicker we accept that as a medical community, the better care we're going to take care of people, and the more likely we are to help people. If we sit on our high horse and say, well, they should just choose not to do it, it's an ignorant point of view, and that's why that number is 64,000. You know, I think that part of that responsibility lies on everybody, because we got to do a better job of treating these folks and taking care of them. And then just a quick, you know, easy way to remember the 4 C's: craving, loss of control, compulsion to use, and not really worrying about the consequences. So this is an unfortunate case. This was actually one of the first few people I saw in Chattanooga. Beautiful young lady. She was like 5'10", blonde hair, works at a golf course locally. Very, very pretty. 23 years old. Was having a party at her apartment with her friends. No history of opioid abuse, nothing. Did have a family history. Her father was an opiate addict, but personally no history. She's over there with evidently, you know, not the best group of friends. They had a bag of heroin, so she decided, you know, I'll try it. Fast forward a couple months later, she shows up in our clinic. She's been abusing IV heroin as much as she possibly can. She's now contracted hepatitis C, and just making one exposure, one time, you know, has dramatically changed kind of the arc and the course of her life. All right, this is a brief overview. Certainly the people in this room are operating at a level probably above this, but just so everybody's on the same page. Opioids, obviously a class of drugs that work on the body's opioid receptors. There's morphine, there's semi-synthetic opioids, synthetic opioids that you can see there. So we use these typically to treat severe pain, okay? Also, a couple other uses, you know, cough suppression, diarrhea, even to treat opiate use disorder, for example, you know, with full agonists like methadone. Very, very effective typically with treating severe pain associated with cancer after an accident or surgical intervention. There of course are strings attached, and that's what we try to stress to folks when we start talking about using these kind of medications, okay? My little tagline is there's nothing free, okay? So yeah, it may help you temporarily, but there's going to be a lot of baggage associated with the consideration of this particular therapy, okay? Just a couple of the things: respiratory depression, constipation, tolerance, physical dependence, just to name a few, are some of the things that we know can happen. All right. Again, just kind of reiterating some of the things we talked about before. One of the big things, especially in addiction medicine, is dopamine. Okay, so that neurotransmitter is intimately involved in most of these addiction-related states. Okay, dopamine produces a pleasurable response, potential euphoria, which can contribute to misuse as people kind of chase after that sensation. And that's, you know, as an aside, that's what we see a lot in our folks who do start taking pain medications that are medically prescribed. You know, at first, and we kind of preempt this when we talk about this, at first it helps them. So they get some relief. But when we get to day 60, day 90, yeah, you know, it just doesn't quite work like it used to. So those are issues that we see over and over and over again. All right. Just to reiterate some of the effects that we talked about: tolerance, of course, needing higher doses to get the same effect. Physical dependence, you know, if we remove the opioid, you know, your body goes through withdrawal symptoms. So how do we get here? There's really been, you know, an evolution over the last few years of trying to move away from the utilization of opioids for chronic non-malignant pain, or at least limiting that. All right, and we have made some significant strides in that. Okay, today, and it'll counteract one of the slides later, but today I was looking at the number of opioid prescriptions written in 2016. Okay, I think it was somewhere in the neighborhood of 214 million, which is down from 255 million about 2012, 2013. So there's been, you know, a pretty significant reduction. There's still a lot more, progress to make. But 1990s, among many other things, this is very, very much just a couple bullet points. American Pain Society, everybody knew that pain was the fifth vital sign, so we wanted to start aggressively treating pain, with hospitals and satisfaction scores and all those things, okay? At the same time, a lot of drug companies that everybody's familiar with now, because they're getting in trouble over this, were touting studies and paying consultants lots of money to say how wonderful the drugs were and that they weren't, you know, there was no issue with abuse, which we know now is false. And during this time, really the chronic non-malignant pain, which I'll keep using over and over, the use for pain medications in that particular category really, really exploded. Okay, and that's really where we saw a huge uptick in opiate use. So this is something everybody's probably seen. United States has 4% of the world's population. We use 99% of the hydrocodone, 80% of the oxycodone, and 65% of hydromorphone, okay, with 4% of the population. a lot of people ask them when they see this, they're like, well, what does the rest of the world do? You know, they don't use that. That's not what. This is showing some data from different points. Okay, so 2015 overdose death specifically associated with prescription illicit opioids increased to 33,000. That number is significantly higher in 2017. What we see is a continuous uptick. And one thing that's interesting is, as I talk about the number of prescriptions have fallen pretty significantly over the past 5 years, the deaths continue to rise. Okay, and so what we're seeing is a transition not just from prescribed opioids, but the transition to heroin for several different reasons. Okay, it's cheaper, it's more readily available, it's kind of been flooded into all of our markets. So that in this town, in Chattanooga where we are, that is happening every single day all over the place. Okay, so we got to just understand that, and sometimes we feel like we live in a bubble. Well, heroin sounds like something far off that somebody else would talk about or use. It's not. It's here. It's you probably within a mile of here. There's somebody that is using or abusing heroin. So the one thing I would counteract that top statement is actually based on the new data from 17. The prescription total has kind of plateaued and is now trending down, which is great. Hopefully us as physicians and providers are doing a better job of trying to really kind of rein in the opiate prescribing. So a couple of subcategories that are worth mentioning. Overdose deaths are highest amongst non-Hispanic white males, 25 to 54, but female overdose deaths are really exploding as well. Okay, so it's truly affecting all sorts of folks. And just a kind of reflection on the changing of thinking, thinking about heroin as something that doesn't happen in places like this. In the 1960s, heroin use was predominantly young men from minority groups living in urban areas. Now those initiating heroin tend to be somewhat older, more concentrated in rural and suburban areas, and white. Okay, so that's kind of how the things have changed with regards to heroin. So another study looked at, okay, these folks that are using heroin, how did they get their start? Okay, so about 80% of those folks reported that they started using prescription opioids for non-medical reasons. Okay, and so that was kind of the gateway or the pathway. That's one of the reasons why it's been very critical. So where do these medicines come from? All right, a lot of times it's family members, friends, grandmother, grandfather, somebody that has access to these kind of medications. So, there's been a big push lately about medication take-backs, and if you're not using the medication, get it out of your house. Don't let it be there and be available for folks to unfortunately get their hands on it that don't need to. So in Georgia, so kind of drilling down a little bit closer to Georgia, the death rates, overdose death rates here, as you can see, ninefold increase between 1999 and 2014. Okay, so huge problem here. Georgia actually ranks 11th, okay, out of all the states in opioid-related deaths. You can see the sales of opioids there quadrupled, but again, those are actually even, based on those numbers we talked about earlier, are kind of curtailing and going down some. This is just a figure for you guys to look at. Drug overdose deaths related to opioids, including heroin. And so the heroin only was there, including heroin, and then all drug overdoses all the way at the top. Okay, so you can see, and that unfortunately that has continued. This is 2015 data was the last data we had there, but as 2016-17, it continues to unfortunately increase. So prescription opioid deaths, overdose deaths. This is teasing out just the prescription deaths. Did dip a little bit, not when you take out the heroin. So again, 11th overall. So very, very big problem here. We think about other Tennessee, Kentucky, West Virginia, but unfortunately we're pretty close to those guys. So this was a kind of a big, so in 2015 was kind of a peak where there were more folks that died from drug overdoses than died from motor vehicle collisions here in the state of Georgia. Okay, and that was the first time that it had ever taken place. The economic impact is huge. Okay, and this is 2013, 2014 because we didn't have a lot of economic data from the last couple years. I would venture to say if it's not 50% higher than those numbers, it may be even higher. Okay, so 2013, $78 billion was what we attributed in the United States, the total cost. And we'll drill down to Georgia here a little bit lower. Going back to 2007, which is really a long time ago with regards to the way things have been progressing, 447 million in 2007. So per capita costs in Georgia in 2007 were $44 per capita. So there's no telling at this point how much higher that number is, but I guarantee you it is very, very, very large. All right, so we understand that it's a huge problem. What can we do to start making progress and making inroads into helping people battle this problem? All right, so we talked about changing the mindset amongst all of the medical community. All right, it's very, very important to understand when you're dealing with 64,000 people dying each year, to take to get off the high horse. Let's figure out what we need to do, even if it's in harm reduction strategies, to try to help these people return to some semblance of a normal life, okay? So I've been in a lot of different scenarios where people would, kind of bash different therapies. Some people say, oh, well, medication-assisted treatment is drug substitution. It's bad. What's bad is 64,000 people dying, okay? We're not in a situation where we have any perfect answers, but if we approach it differently, I think we can do a lot better, okay? So understand better the disease itself, the implications for those affected. Again, going back to what I said earlier, not a moral failing, not just a choice, it's a real disease process. This also involves working with our legal system, okay? Something that I'm starting to get involved with here and also in Tennessee is integrating ourselves into that system, okay? So the answer, which we've done, everybody's familiar with the war on drugs from years past, the answer turns out is not just to lock these people up for 10 years and then turn them back out to the streets, okay? That doesn't work very well, all right? There has to be a better process and program in taking them and reintegrating them in the system. Because guess what? The underlying process is still there. What got them, addicted to heroin, it's still there. And so if we don't address that, guess what? You're turning them back out and we're just gonna have to go pick, you're gonna end up picking back up and put them back in jail, all right? Improving access to treatment that is legitimate and affordable, okay? So those last two things are very big, all right? Unfortunately, when you have a situation like this where there is a really big problem and there is potential for money to be involved, to be made, you're going to attract some people that want to do the right thing, but you're also going to attract a lot of people that really just want to make money off this problem, okay? And so up until last year in the state of Georgia, if my cousin wanted to open up a drug treatment facility, they could just open it up. It was a very low bar. I mean, I say that in jest, but it really was not very difficult. It's changed this past year to where the restrictions and there was a freeze put on, and now it's very, very, very challenging now to do that, okay? So that's both good and bad, okay? It's good that we're keeping the bad actors out, but it's also difficult because now we don't have, it's a much higher bar for people to get over to actually open a treatment facility here, okay? And affordable. So outpatient treatment in most parts of this area, specifically in Tennessee and in Northwest Georgia, it's typically a cash-based model, okay? So if you come and you say, okay, I'll pay you $400 a month and in cash, and we'll see you and we'll write you a prescription for some medicine, and we may or may not have a counseling and group therapy involvement. That's kind of how the model was, still is, all right? So one of the things that we're trying to do is break that, all right? To change that in a positive way, to legitimize it as a medical treatment, to help people who have insurance or who have access to insurance, that we accept insurance, that we take care of those patients, and it's not just dependent on them giving us $400 in cash, which is, you can see the problems with that idea. So what are we specifically as physicians doing to combat this? All right. The first thing, which is very important, limiting opiate prescribing in general. Okay. So I would say, being in kind of a unique position on this, I would say in the last 12 months, the amount of patients that I've started on opioids, you could probably count on both, one hand or two hands, okay? The reason that is I do not have a high level of conviction and belief that that is the right answer, okay? Will it help somebody temporarily? Sure. You know, taking out, of course, we take out cancer-related pain. That to me is in a different box, okay? We treat that differently, and I think that's appropriate. But for chronic non-malignant pain, it's kind of becoming a, you know, kind of a come to Jesus time. I don't know where the future is going. I don't know what's going to happen over the next 5 years, but I think there is a legitimate possibility that opioids for chronic non-malignant pain are going to continue to be squeezed upon and squeezed upon, okay? And I can't, in all honesty, say that I disagree with it. I mean, I see people that have been on the medications for 10 years, 15 years, 20 years. Does it help them? I mean, they say it does, you know, but would they, if they tapered off and got away from it for 60 days, 90 days, would they be about the same? I don't know. Certainly possible, all right? So kind of along those lines, utilizing opioids as a last resort therapy for that particular patient population. So doing everything we can, using a true multidisciplinary approach from physical therapy, exercise, weight loss, different classes of medications, interventional techniques, smoking cessation. That's something that we've really been trying to harp on recently to try to help folks. I mean, the truth is, if we can get them to stop smoking and we can get them to lose 20 or 30 pounds, guess what? You're probably going to feel better, you know, after you get through that. So that's something that's really, really, really big that we're trying to work on. Screening patients prior to them having any sort of prescription. That again is a very critical part of it, okay? Identifying patients who are at risk. Essentially what we do is, on our intake, we've got a variety of different things. We obviously look at drug screens, we look at the Pdmp, which we'll talk about in a second, and we do a risk stratification based on a couple of different validated tools, and try to come up with a classification of that patient. You know, we take them to low, moderate, and high risk. You know, if you're low risk, we'll consider it. If you're moderate to high risk, it's probably not the best idea, okay? Again, the Pdmp, which everybody I'm sure is intimately familiar with now that the new legislation's come through. This is something that we've been doing ever since I first stepped foot here. Kentucky created CASPR, which was the first statewide, you know, prescription monitoring. And we're supposed to be NASPR, which was a national database. The legislation went through initially, but it was never funded, so it never happened. But we had CASPR in Kentucky the whole time I was there, and it was a huge tool because you could see, you know, at that time there were still people who would try to do that, who would try to doctor shop or you know, get medications from multiple locations. So that's obviously very big, and now that's being mandated into the prescribing. You know, except for a couple carve-outs, post-operative pain, cancer pain. There's a couple of carve-outs for that, but that's something that everybody's going to have to deal with. The CDC guidelines, another thing that we're, you know, again, they're guidelines. They're not mandated rules by any stretch of the imagination, but most of the stuff in the CDC guidelines we were already doing. We never really adopted any policy of high-dose prescribing of pain medications. This is a big one that we've been working on the last 12 months, is the co-administration of benzodiazepines and opiates. So there has been kind of a movement completely away from that. And unfortunately in our community, that is a big problem. I mean, everybody that walks through my door for a while there was on Xanax and oxycodone and wanted me to take over, you know. So that is a huge issue. And what we've come to now is essentially this. Like we tell our patients, if you're on a benzodiazepine like Xanax, then you're not a candidate for oral opioid therapy. And that's a tough spot. I understand that puts people in a difficult position. You can do one or the other if they're indicated, of course, but not both. And so that we've gotten, my brother's here and he's been helping with, we've probably gotten, 300 people off benzodiazepines in the last 12 months, which doesn't sound like a big deal, but I mean, and the funny thing is almost all those people come back. They're like, man, I feel better. I feel like alive. I've been in a fog for a decade, you know, but you take it, you don't really realize that until you're able to get away from it. Again, educating the community about appropriate, you know, opioid prescribing from the emergency department to post-operative pain into the primary care setting. So some of the other things that we're working on, we talk about medication take-backs. which is just trying to get the supply, decrease the supply of available pain medications and whatnot off the street. Youth education and prevention, law enforcement that I mentioned earlier, working with the drug courts, trying to find ways to get these folks into treatment and affect their process a little better. Other things, so reversal agents, the widespread availability. Now there's a big push to make Naloxone, Narcan available in a bunch of different settings, okay? Everything from, we've got, Evzio is a company now who I'm sure is making a lot of money, but they've got an auto injector, kind of like an EpiPen, that a lot of our folks have, just to have on site in case of that emergency. Medication-assisted treatment and recovery support. So what we do at Restoration Recovery is try to put things together to try to help the patient, okay? So with a basis in counseling, group therapy, meetings, social support, and the utilization of medication-assisted treatment, okay? There's a couple of medications that are used for that in the setting that we're in, all right? And we'll talk about that in just a second. Other options, okay? Outpatient treatment like we talked about, IOP or intensive outpatient treatment, which a lot of our folks are involved in. We've got great relationships in Chattanooga with Bradford Health, with Focus, with CADIS, all the big organizations there who work closely with us. If patients need inpatient treatment, if they need IOP, they've been great about really working with us there. Residential treatment, everybody's familiar with this. You go away for a period of time and receive treatment there. There are a variety of different really good places and really not so good places in that space. So it's really important to choose wisely. Detox, so rapid detox, folks come in going through withdrawals or issues and rapidly detoxified. Medications we mentioned there. So Naloxone, again, antagonist, okay, binds the receptor and reverses some of the effects of opioids. Has no effect if you just don't take any opioids or don't have any opioids in your system. There's been a big push to expand access, so standing orders at pharmacies, getting that out and available gives us a chance to save some lives. I mean, it is truly a life-saving therapy if it's indicated. So medication-assisted treatment, that essentially boils down to those three medications, all right? And we're going to spend more time on the bottom two, all right? The first is Methadone that you see there. It is a full agonist, okay? So it is an opioid in and of itself with full agonist capabilities. This is dispensed in methadone clinics that I'm sure everybody's familiar with. So, either daily dosing or take-home dosing. Patients go there either daily or very frequently, get their medication, take it, may or may not have a counseling session, and then go home. Again, there's some good people in this particular space too, but there's also a lot of people that are not as good. People that are just interested in making money. So it's very important to be in the right setting if that's the path that you choose, okay? And this is not to put that down in any way. Like I said before, all options are on the table when we're dealing with a problem like this. So if you tell me, I'm injecting heroin every day, but then I went to the methadone clinic and I'm taking my medicine, I'm back at work, I'm doing better. Listen, I can't argue with that change, okay? And that harm reduction is very valuable. So there are different options for different folks. So buprenorphine is a very interesting drug. It is a partial agonist, so it binds to the opioid receptor very tightly, which comes in pretty handy, okay? It has ceiling effects on things like respiratory depression, some of the scary side effects, so that's important. But the fact that it binds to that receptor very tightly typically means if buprenorphine is on there, it's very hard to displace that. So say my patient is, oxycodone is their drug of choice, and they're on buprenorphine maintenance therapy. What they find very quickly is that they might be wasting a lot of their money if they take or ingest oxycodone because it's not going to be able to attach to that receptor, okay? It's just going to circulate and then it's going to get excreted and then they're like, man, I wasted $50, So that is a very important component to that. That comes in a lot of different formulations, okay? There's some really exciting things happening here with buprenorphine. So there is injectable, okay, which is Sublocade, which is a once monthly injection, which is really cool. That helps us with compliance, of course, but it also helps from a diversion standpoint, okay? Because what we also know is that buprenorphine, even though it's a treatment for this, is diverted, okay? People buy and sell it, maybe for different reasons. I mean, some people will inject it, but a lot of folks will buy it off the street because guess what? It's going to prevent them from going into withdrawals, and it's cheaper than, buying other options. Naltrexone, there's been oral naltrexone for a long period of time. What we think about a lot now is Vivitrol, okay? So patients that'll get an injection with essentially an antagonist to help blunt the effects of any ingested medications, okay? So that's another kind of as a transition point for some folks. If they're not, what we see is folks that are just starting out may tend to do a little bit better with medication-assisted treatment, and then at some point our goal is to get them where they don't have to take anything, and if they need to take Vivitrol or something just to help encourage abstinence, then that's great. The big thing is down below, okay? So I'd be the first to tell you that medications are no magic pill, okay? What we tell folks is that you take, if we use medications, we're using that just to kind of put the fire out in your brain while we allow the other modalities to really work, okay? So the social support, the counseling, the group therapy, all those things are critical to recovery for our patients, okay? So we take that very seriously. That just kind of runs through the treatment options again. So this kind of, to wrap up, this is a different thing that we've kind of already touched on, but do opioids have a place in chronic non-malignant pain? This is a tough question, okay? There are no long-term data to support their use. I will say that to start with. There's actually, the SPACE trial that was released recently, which, I don't know if it's the greatest study, but it gave us some good information that really the outcomes are no better than non-steroidal anti-inflammatories and acetaminophen. So that is at least worth thinking about when we start talking about, should I give this patient an opioid to take for some form of chronic pain. And what do we do with all our legacy patients? Okay, so the last 2 decades we've got patients that have been ramped up on different pain medications. How do we take care of them? I think the answer is kind of a mixed bag. Some folks will be able to get away from pain medications. Some will be able to taper down. I don't have all the answers for that yet, but I think it's on a case-by-case basis. Excuse me. This is our clinic. It's on Chaliford Road in Chattanooga. If anybody is interested in talking to us about this, we're always looking for additional folks, be it doctors, any of the providers, mental health providers, any of that would be great. Questions?